Good evening, everybody. Welcome to Pull Up with Limbs and Things. My name is Dr. Chanel James, and I am the owner of Limbs and Things mobile and telehealth practice serving DC, Maryland, and Virginia for aging adults, helping you move from I can't do something to I can. Tonight, we have Dr. John Ferrell. He is the owner of ROSM, and they are a orthopedic and sports medicine company in DC, Maryland, and Virginia. And Dr. Farrell, it's good to have you tonight. How are you?
I'm doing excellent. Thank you so much for inviting me.
Sure. So tell us a little bit about all that you do at ROSM.
Yes. So, as you said, ROSM stands for Regenerative Orthopedics and Sports Medicine. We have 6 locations in the greater DC area, 2 that are in Virginia in Tyson's Corner in Reston, 1 in DC off of 19th Street, and in Maryland, we have 1 in North Bethesda, Columbia, and Annapolis. So we have 10 physicians and 3 physician assistants that all specialize in non-surgical orthopedics. And so non-surgical orthopedics is really using musculoskeletal ultrasound to help diagnose the problems that you have, tears in your rotator cuff, tears in your meniscus, chronic tennis bell, Achilles injuries, or plantar fascia. And so that also gives you a proper diagnosis in real time where you don't have to worry about leaving the office, going in to get an MRI, then having to come back and take off work again to see and go over the MRI. We're able to do that right in office and get that done at that point in time. And then we can immediately talk to you about treatment options that are non-surgical. And so a lot of those options can be physical therapy, sometimes medication to manage things. But we also have a lot of injections that don't involve cortisone that can help to repair, heal, and get things better.
That's awesome because a lot of patients that I tend to see have pain issues, some of which we want a short-term pain relieving option, and then some that are more willing to take the long-term pain relieving option. So I've had a patient who has had cortisone injections in their hip, and it has been not as successful. And so they're looking for other alternatives. What would you tell someone in that instance?
Yeah. Well, we really want to get down to the root cause of it. So what is causing your hip pain? Is it hip joint pain? Is it lateral hip pain? Is there tendinopathy or tendonitis of your glute tendons as they come and attach on the outside of your hip? So a lot of that information we can get from either combination of x-rays and ultrasounds or things that are really complex. Sometimes we'll need an MRI. So let's take, for instance, if this pain is coming from the glute tendon attaching on the outside. A lot of times people can have partial tears there and not realize it, that we can visualize on ultrasound. But not only can we visualize it, we can say, hey, let me do a diagnostic test to see if this is where your pain is coming from. So that means I'm going to put a little bit of lidocaine directly into the tear. I'm going to retest your strength, have you go walk, have you try to step up on a stair and see if your symptoms have improved. If your symptoms have improved, I know I got the right diagnosis. And with that right diagnosis, then we can talk about treatment options. So you've already tried cortisone, the cortisone didn't work. One of the next steps may be something called prolotherapy or platelet-rich plasma. So prolotherapy is an injection of a concentrated solution of dextrose and lidocaine. Literally, it's a sugar. So sugars are not supposed to be in our tendons, and so when we inject them in there, it creates an inflammatory response. That inflammatory response lets your body know that you've been injured, so they're going to send stem cells down to try to repair and to heal. So prolotherapy works really well for a lot of these small partial tears, just works a little slow. So most people usually need about 4 to 6 sessions of prolotherapy in order to get things to completely heal up. And the wonderful thing about musculoskeletal ultrasound is that we can continue to ultrasound it every month as you come in to make sure things are filling in or getting better. Now, some of my type A DC patients, they're going to say, hey, 6 months is too long. I need something faster. I need less shots. What else do you have? And that might be when we talk to them about platelet-rich plasma. So that's where we take your own blood, we spin it down in a centrifuge, and we separate out the red and white blood cells, but we keep the platelets. Those platelets contain growth factors that serve as a magnet or a beacon to tell the body's stem cells where to go. And they start to heal and repair. So the analogy I often use is, let's say you're working in the yard, and you get a cut on your skin. So the platelets are going to go there and form that clot, so it's going to stop you from bleeding. They're going to release their growth factors. And when they do that, that's going to cause stem cells to that area there. So when that scab falls off after a week or two, you have a scar that wasn't there before. That's brand new skin tissue that developed over that 2-week period. And where did that come from? That came from those growth factors that the platelets left there to call those stem cells down to repair that.
And they're doing that inside muscles or joints wherever you inject.
Absolutely. So, and that's the beautiful thing about, when we're injecting into tendons and ligaments, we can watch them with ultrasound and watch them over time fill in. We can see that healing.
That's great. So we want to give you all an opportunity to ask questions. So if you would put your comment in the comment section and we can ask them. And we also want you to remember this is information that we hope that you can share with someone else, challenge something to confirm something as well, but to also give you an opportunity to share that information with somebody else. So here's a question for you. Do you use holistic approaches like CBD to minimize pain?
Absolutely. We think that CBD is a great anti-inflammatory, and it may have less of the damaging effects on kidneys and liver. And so, if patients are using CBD to decrease inflammation, and now that they have less inflammation, they're able to work harder in physical therapy. I think that that's a great thing. Now, I don't typically use CBD necessarily in combination with some of my regenerative treatments because I'm trying to create an inflammatory environment in order to stimulate some healing. So I'd actually have them hold off on CBD for about 2 weeks. And then after that inflammatory reaction has already occurred, they can restart the CBD.
Now, when you're talking about CBD, are we talking about the topical type?
It can be topical or oral. The benefits of topical is you can put it exactly right where your pain is. But when you take it orally, also, you usually are going to get a higher concentration. It's going to be absorbed systemically in a higher amount, and it's going to work probably as a stronger anti-inflammatory when you're taking it as a tincture.
Okay. Is anyone better than the other, or does it depend?
Yeah, so I think that there's a lot of research that needs to be done to determine what is better, what is the optimal amount of CBD, what is the optimal dosage. Right now, it's best evidence is really, you titrate it to the person. You look at your symptoms, you look at the amount of pain they're having, the amount of inflammation they're having, and you can titrate the dose in order to match that. There's also some questions on whether or not adding THC in there is going to have a better result than just CBD alone. But that, especially in the DC area, when we have a lot of people with top secret clearance and things like that, they have to be careful because then, they can pop positive with THC and get themselves in trouble.
And we don't want that.
All right.
All right, here's another question. Hello, Ms. Foster. I've read that adding magnesium helps with arthritis pain. She has pain in her knees. Is this true?
There have been some studies that show that magnesium can help out with pain. You have to be careful with magnesium. Magnesium is one of the ones that can also affect your nervous system and your muscles. And if you take too much magnesium, it can actually be damaging or harmful to yourself. So you want to kind of follow recommendations and also discuss that with your physician.
For sure. Just a comment. Hi. Great topic and interesting discussion. Thank you. So again, if you have questions or comments, you're watching and you want to have a question answered about your pain relief by Dr. Ferrell, please put your question in the comment and we'll answer them. I have a few. Let's see. What's a good candidate profile for cortisone injections versus the prolotherapy that you mentioned or the plasma rich?
Yeah. So with cortisone, cortisone has the potential to have detrimental effects. There have been studies out there to show that repetitive cortisone shots can cause your arthritis to progress at a faster rate. There have been studies out there that show that cortisone can actually stop the normal functioning of tendons. So they can actually lead to you going from tendonitis to partial tears in your rotator cuff or in your lateral epicondyle, so your tennis elbow. So we want to use cortisone sparingly. So typically in my hands, if somebody comes in after an injury, a trip or fall, and let's say their knee joint is swollen and irritated and they can barely walk, I'll bring them in and we'll pull the fluid off of their knee and I'll do a one-time cortisone just to kind of calm things down. And another example would be if somebody says, hey doc, my knee's killing me, I'm about to go on a trip to Disney World with the family and I want to have a good time. Is there a quick fix for me? Cortisone is a great quick fix. It's a strong anti-inflammatory. Usually lasts in your system for about 4 weeks, sometimes a little bit longer, sometimes a little bit less. But it really kicks in there quickly to decrease the inflammation. But we really don't want to overdo it just because of all the damaging things that we talked about. And then also it can do things like cause your blood sugar to elevate also. in diabetics, so you want to be careful with those. Candidates for some of the regenerative options really are the candidates that I think fall into what we call a treatment gap. So the treatment gap are people that aren't getting better with conservative options. Those your physical therapy, that's your anti-inflammatories, that's your CBD, your topical creams, your knee braces. People that I've tried all of that, I'm not getting better. They may or may not have tried, a cortisone injection. If they have osteoarthritis of the knee, another one is something called hyaluronic acid. And I think that's a good treatment option for people that does not have any of the detrimental effects of cortisone. It's a gel that's thick and viscous and help to lubricate the joint. You also see women using that on their face. And so hyaluronic acid is a nice option for that. But then, the people that fall into that treatment gap that have tried all these things but aren't ready for a major surgery, that's when we can look at prolotherapy, platelet-rich plasma. There's something called bone marrow aspirate concentrate. It's where we actually get mesenchymal stem cells out of your own bone marrow, and something called microfragmented adipose tissue, or MFAT for short. And that's when we do a mini liposuction to actually pull fat out of your glutes or out of your belly, and we inject that fat into the area of pathology. And so the reason why we do that is fat contains mesenchymal stem cells. It's thick, it's viscous, and provides cushioning. And that cushioning can provide lubrication and severe knee osteoarthritis. It can actually help to bind and help to kind of fill in when you have large rotator cuff tears. So there's certain areas where even prolotherapy and PRP aren't going to be strong enough, and that's when we're typically using bone marrow and fat.
That's really good information. Let's see. How does icy hot work for pain?
Yeah, so icy hot, one of the main ingredients in there is the menthol. And so the menthol gives you a tingling sensation when you put it on. And essentially what it's doing is it's confusing your nerve fibers. So it's not focusing on the pain of your joint or your, the tendon. And it's trying to figure out why are you having that tingling sensation. And so, as long as that tingling lasts, usually you get pain relief. Once that wears off, then the pain is still there again. It's a temporary measure, but it's perfectly fine if you're uncomfortable in pain or don't want to take oral medications, but it's not doing anything to fix the underlying condition.
Right. Here's another one. How can a person determine when they should come to you versus going to their doctor to determine if there's another way to relieve the pain?
Yeah, so we are non-surgical orthopedists, so it's a mix of primary care sports medicine doctors and physiatrists. If your insurance allows you to go directly to the specialist, we are more than willing to evaluate you, give you a second opinion on your pain, and help you kind of come up with a plan that's going to treat the underlying root of the pain. Some people that are in a HMO or they need to have a referral in order to go see a specialist should probably start off with their primary care physician first, get that initial evaluation, get a referral, and then from there you can come and we can kind of evaluate you.
Does ROS or ROSM, do you guys take insurance?
Yes, we take most major insurances, and half of our providers take Medicare, but not all.
Okay, good to know. Does turmeric, betadine, biofreeze, and blackberries have any effect on muscular pain?
Let's take them one at a time. So yes, turmeric's a great anti-inflammatory. It's been used in India for hundreds and hundreds of years. And right now, we can find turmeric either naturally or in supplements where it's actually concentrated, so you're getting a high enough dose. And there have been head-to-head studies that find that turmeric at a high enough dose can actually be just as effective as your classic anti-inflammatories like Motrin, Advil, or Aleve. To my knowledge, I'm not familiar with betadine specifically having an effect on muscular pain. Biofreeze actually does. It has menthol as their active ingredient. I think it also adds MSM and chondroitin in there, which are two supplements you can also take orally that actually have good literature to support its pain relieving effects on muscular and orthopedic and arthritis pain. And blackberries are just kind of known as anti-inflammatory foods. You'd have to take a pretty high dose or a very high amount of blackberries in order to it to be effective as an anti-inflammatory pill. But yes, taking blackberries on a regular basis can be beneficial.
Thank you. That was so thorough. Let's see. What's your opinion on the effectiveness of manual therapy in pain relief?
I think that a good physical therapist, especially a good manual therapist, is worth their weight in gold. And I think that a lot of musculoskeletal pain comes from poor biomechanics. And so if you can have somebody look at your whole body, look at your biomechanics from, do your feet collapse? Do they roll in? Are your knees buckling in? Are your hips in or out of alignment? Anyone that can look at that whole thing and help you correct that, help you work to strengthen your core, strengthen your glutes, and work on stability, that's going to have a great effect on a lot of your pain.
I agree. That's a physical therapist you're speaking to. Okay, so tell us about epidural shots and cortisone injections and the difference, or if there is one.
Yeah, so epidural is just telling us the space that we're going into. And so if you're getting an epidural, you always have to have a conversation with your physician on what they're injecting into the epidural space. The purpose of doing epidurals, usually musculoskeletal pain, is usually to treat kind of disc herniations that may be contributing to low back pain. Vice versa, if you're pregnant and you're getting an epidural, it's usually lidocaine just to kind of numb things up before you deliver a baby. Most pain medicine physicians that are doing epidurals are typically putting cortisone in there. And they're using cortisone to try to bathe the disc that's bulging or herniated in order to get it to shrink up and therefore not compressing on a nerve root, giving you pain radiating down your leg. Usually, they'll do 1 up to 3 of these cortisone injections in order to try to help relieve your pain. Right now, we're getting a lot more data and evidence to support using plasma in the epidural space. And so some of the benefits of using plasma in the epidural space is that they can sometimes cause the disc to shrink and relieve that pressure off of the nerve. They can also, they won't have any of the detrimental effects of the cortisone. So you're actually using something natural, something from your own body to help treat this disc bulge in order to get that better. And then you can also use plasma in the facet joints around that area there. And there are some studies using plasma into the disc itself in order to help out when that disc has been ruptured or dehydrated. So there's a lot of good uses for plasma in and around that area there. But I think that when we even take one step back before we start doing epidural injections, I think it's imperative to have somebody who understands the pelvis, the lower back, to really take a look at your alignment, to look at where your pain is being generated from. And so a lot of times I can see SI joint pain mimic facet pain or mimic epidural pain. We can see a lot of paraspinal atrophy, and that's one of the beautiful things about ultrasounds. I can actually visualize and see your multifidus muscle as it's running up and down your spine. And I can say, well, yes, you have a disc bulge, but I'm not sure that that's the source of your pain. Let's try some diagnostic injections in your multifidus muscle, see if that actually relieves your pain. Let's work with a good manual therapist to realign your hips. And if you get temporary relief when we realign your hips, that's telling me there may be some instability of the pelvis that's leading to your back pain. And if your pelvis is unstable, a lot of times you're not able to activate your glutes, right? So you're in therapy, you're doing your squats, you're doing your bridges, your lunges, and you keep hearing your therapist saying that glute's not activated. Or, your personal trainers, when you're doing your squats, are telling you that glute's not activated. Well, to me, that's a red flag saying that your hips are probably out of alignment. If your hips are out of alignment, that causes your glutes to be overstretched. If your glutes are overstretched, your body's response is turn off. Why? Because glutes need to cross hatch in order to activate. And if you're overstretched, you're putting it at risk for a rupture. So your body's natural response is, hey, let's turn off your glute so you don't rip it. And so, these are all the things that you want someone to look at before they just say, oh, your back hurts. MRI says you have a disc bulge. Must be that. Let's start doing epidurals. Let's take a step back and make sure we're looking at all the entire picture before we jump to that.
Right. That was very good. I think we tend to miss the importance of finding the actual root cause of the problem before we just go and treat the pain. So thank you for bringing that out. Let's see. You have another question. Why do some surgeons not refer patients to physical therapy after back and neck surgeries? And then you want to answer that one first, and then I'll say the second one.
Well, yeah, the first one should be a pretty quick one. I don't know why they wouldn't refer back to physical therapy after a back and neck surgery. Essentially, anytime you do a back and or a neck surgery, you're cutting through fascia, you're cutting through skin tissue, and you may get rid of that disc that's bulging, if they did a micro discectomy. But now you've cut the stabilization, you've cut things that are going to lead to scar tissue and lead to atrophy of the muscles around there. So I think that anybody after surgery really should be doing physical therapy.
Sure. Okay. How can physical therapists improve reimbursements for manual therapy and other modalities?
Yes, that's a tricky one. What we see is so many good manual therapists going out of network because they want to treat the way that they want it, that the patients really need to be treated. And the reimbursement rate, the way it's set up, it's like most people have to see 3 to 4 people an hour in order to pay the bills. And so people will say, "Hey, I'm going to go out of network because you can pay me just like you pay your personal trainer, and you can get reimbursed what I was getting reimbursed if you submit it to your insurance." And so we see a lot of manual physical therapists doing that. I think the other way that's going to be a longer route is patient outcomes, right? And so if you can record your patient outcomes and say, "Hey, when we have somebody with a rotator cuff tear that got treated with surgery or treated with an injection, and it took them 4 months to be back to 90% normal, versus when they worked with a manual therapist, we got them back in 3 months." So if you can document that you can have improved outcomes, that's one way that you can go back to the insurance company and say, "Hey, if you guys pay for me or pay for me at a higher rate, I'm going to decrease total cost by decreasing the number of times they have to come in."
Oh, that's really good advice. I appreciate that.
Absolutely.
What are your thoughts on opioids for pain?
Not a big fan. So opioids for pain, short of, cancer pain, is a really, really slippery slope. People start to get dependent on that very quickly. And once you start getting dependent on opioids, it changes those receptors. So even people that are using it for a short period of time, anytime they get any other pain, they're not going to respond to the Tylenol, to the Advil, to the Motrin, because they're used to having such a high level of pain medication.
Mm-hmm.
And so it's a really slippery slope that I'd much rather focus on the underlying cause and managing that rather than just giving you a pill to mask it.
That's so true. Okay, so this question, why does a puffy elbow return after draining?
So typically a puffy elbow can come from one or two different areas. One is if the actual elbow joint itself was full of fluid, which can happen in arthritis or trauma. But the more common way is usually there's something called an olecranon bursa. A bursa is a fluid-filled sac that sits on the outside of the elbow. And a lot of times if you've leaned on your elbow, got hit on the elbow, that bursa can get inflamed. It can get full of fluid and become puffy. So a lot of times, orthopedists will go in there and they will take the fluid out of there and send the fluid off to make sure it's not infected. B, look to see if it's bloody. If it's bloody, more than likely it's not an infection, it was trauma that caused it. And then sometimes they'll put cortisone in there to try to decrease the inflammation. And they usually try to put a wrap around it to try to prevent it from filling back up. That bursa, once it's irritated and inflamed, it constantly wants to produce more fluid. And as it has more fluid, it causes it to swell again.
Mm-hmm.
And so, that's why putting that injection of cortisone in there tries to help to calm that down. But if there was not enough compression before that cortisone kicked in, it can easily fill back up. It can be drained again. You can use other things besides cortisone in there to try to decrease the inflammation. But if it's something that becomes perpetual, it just keeps coming back, despite having it drained multiple times. There is a quick and easy surgery that they can do, a same-day surgery, where they can actually just remove the entire bursa.
Mm-hmm. Good to know. All right. Again, this is an opportunity for you to ask your pain-relieving questions to Dr. Ferrell. If you have any physical therapy-related ones as well, I'll answer those. And you can put your question in the comment. If you're with us, it looks like it's about 10 of you on, and we can't see you. So you can hashtag live in the comments, and then we'll know you're here. If you're catching this on the replay, you can hashtag replay as well. Let's see. I think I have another question for you.
Sure.
Let's talk about what role weight plays in your pain relief.
Yeah, I think it really talks about where your pain is. If your pain is below lower back or lower, weight can definitely play a large part in some of your pain. There's an old saying in orthopedics that every pound you lose off of your belly is 3 pounds off of your knees. So even losing a small amount of weight, 5 to 10 pounds, can actually make a big difference in the amount of pressure that you're putting on your knees. A lot of times it's a catch-22 though, because patients are in pain and they're like, hey, if I could work out, I'd be able to lose some of the weight, but I can't work out because my knees hurt, my hips hurt, or my back hurts. And so that's why we try to focus on getting the underlying symptoms better, decrease the pain through there so they can become more active. And as they get more active, then they can lose the weight and then hopefully prevent this from kind of coming back. And so I have patients that, we treated both knees, and as we treated the knees, had pain relief for 3 to 5 years, allowed them to lose 50 pounds. And now they're doing great, feeling great. And, normally the time that some of these injections will wear off, they haven't, because they've lost that large amount of weight. And so they're not pounding the knees as much as they were before.
That's great. Tell me that ratio you gave again about weight loss from your belly to your knees.
Every pound off your belly is approximately 3 pounds of weight off the knees.
Got it. Okay. Any questions you have for us? We'll give you a few more minutes to join and ask. One last question from me. I want to know, from your perspective, what do you recommend physical therapists do to be more communicative with physicians on the ways that we're working on relieving pain, so that we're all working together to help the person to have a total weight loss holistically?
Yeah, so that's going to depend on each physician and each physician group. So I can speak for our group. We love to communicate with physical therapists. So most of the physical therapists that we work with have our email, have our personal cell phones, and they'll text or email us back and forth. We think it's imperative to have a group approach. And so when the patient is hearing the same thing from me that they're hearing from you, and we're all on the same page, there's no question who's right. There's no question, does this person know what they're talking about? Or I'm confused, who do I follow? And that way we don't step on each other's toes. So I think it's imperative to have that communication. And so sometimes you guys see patients, and you usually see them more than we do, and you pick up on little things that would be super helpful to know about. Sometimes we see certain things that you guys are like, oh, I didn't think of it that way. And so having that communication is really, really helpful. And so usually we do that, electronically through email and or text.
Very good. Okay. I think I missed this one. Why do manual therapists focus on facet joint instead of spinous process, which is easier to palpate than a facet in the spine?
I think it's because we use MRIs to diagnose instead of physical exam. So unfortunately, everybody gets the MRI and they're focused on, what does the MRI say? What does the MRI say? Because that's going to tell me exactly what causes the pain. And if you get to do your physical exam, to do your manual work, to listen to the patient, to hear exactly, okay, what type of things aggravate your pain, what makes things better. And, as you age, we're going to find facet arthropathy. And that's just a fact of life. I tell people pretty much when we start getting MRIs of your back and you're over the age of 40, I'm going to find something. Just because I find something doesn't mean it's your source of pain. Yeah. And so I think that's just an important thing to look at. And so some of it is trial and error. Some of it can be diagnostic injections. Some of it's really kind of putting all of this together to figure out what is that source of pain for you. And then once we kind of do that, then you can change your physical therapy to focus on if it's spinous process related pain, if it's facet joint related pain, if it's disc related pain, or if it's just hip and SI joint related pain, atrophy of multifidus, atrophy of glutes. These are all things that you can kind of work on.
Here's another one. What can be done to eliminate nerve pain in your legs? I was diagnosed with venous reflux disease, but it has been stated as significantly cured, but the leg nerve pain continues.
Yeah, so unfortunately, the venous reflux disease can be associated with nerve pain, but not necessarily the cause of the nerve pain. Nerve pain can be complex. Sometimes it can be from your back. If you have a disc herniation or disc bulge that can compress some of the nerve roots coming out of your back, that can kind of cause some nerve pain going down your leg. Sometimes it can be to what we call neuropathy, where the nerves just aren't functioning. Neuropathy can be caused sometimes by diabetes, sometimes by medication. Sometimes it can be idiopathic. That's a fancy term that means the doctors don't know what's causing it. So, depending on, what the source of your nerve pain is, you can treat that source. So if it's coming from your back or your disc, you can focus treatments in around that area there. Another area where sometimes this can happen is you can get what's called a nerve entrapment. Sometimes you can form scar tissue around the sciatic nerve or some of the other nerves radiating down the leg. And if that's a source of your pain, a lot of times under ultrasound, we can see where that nerve can sometimes be compressed. We can treat that with actually saline and lidocaine in order to relieve that compression. So imagine you drove your car on a garden hose, it's compressing that hose and it's not allowing the proper flow. So once we relieve that compression off of that garden hose, it allows things to flow a lot better, and that can sometimes help out with your pain. There are oral medications that you can use to mask the pain. The benefit is, hey, you got to take a pill and it makes things feel better. The downside is now you're on a pill pretty much for the rest of your life in order to mask that pain. So, you really have to get a little bit more information to figure out where that pain is coming from. So that might involve MRIs in the back. It might involve ultrasounds looking at the nerve. It might involve an EMG nerve conduction study to test the nerve to see where this is kind of coming from and what may be the underlying cause.
Thank you. Okay. That made me think of another question.
Sure.
I have a patient who's recently been complaining about sciatica. And then I have a lot of people that just ask random questions that'll be, I think I have sciatica. Do you have any methods to determine and to treat sciatica that are not widely known?
Yeah, so with sciatica, I usually think of sciatica coming from one of three different areas. One can be disc herniation in the back, compressing on the nerve root. As it does that can give you pain radiating down the leg. Two can be from the SI joint. That's short for sacroiliac joint. That's where that pelvis kind of forms. And if that pelvis goes out of alignment, it can sometimes compress and irritate the nerve roots. And that can kind of cause pain to radiate down the leg. And then three is usually a compression right around the piriformis muscle. So the piriformis muscle usually sits on top. The sciatic nerve comes right underneath. And then another muscle called the obturator internus sits right underneath that. And so that can kind of get skinny.
Tell people where you're talking.
I'm talking right in their butt. This is a pain in the butt. And when you're getting that compression right in that pain in your butt, that can cause that pain to radiate down your leg. So some of it is teasing out where is this coming from. So sometimes an MRI of your back can help out to see if there's a disc herniation. Sometimes having your SI joint manipulated or even a diagnostic injection into your SI joint can help out. And then sometimes doing an injection right around that piriformis muscle and treating the sciatic nerve at that level, that can help us diagnose things also.
Okay, thank you. Please explain acupuncture for pain.
Yes, so acupuncture for pain, literally goes back thousands of years to the Asian continent. And for a long time, Western medicine did not want to accept that because in Western medicine, we know where nerve roots respond to. And the map for acupuncture does not match up with our map. So we said, hey, this stuff doesn't work. It has to be voodoo. It has to be, placebo effect. But there's been a number of level 1 studies, double-blind, randomized controlled studies, kind of looking at acupuncture and seeing that acupuncture actually does have a good relief on pain. Now, I can't necessarily explain it as well as somebody who actually practices, more kind of Eastern medicine. But overarching, general idea is that the body has a map of pain receptors for certain body parts. And putting those needles near that map can help to relieve pain in certain areas. And that's about the best that I can do before butchering or ruin it. I don't want to offend any acupuncturists that are out there.
Well, thank you. That was good. So a follow-up to that is a lot of physical therapists use dry needling. Do you know the scientific basis for dry needling?
So, yes. So I think that, people hear dry needling, they hear acupuncture, they're like, it's the same thing. And I kind of tell them that, the similarities are that they use the same needle, and that's about where it stops. And so typically dry needling is using to treat muscles that are tight, that are in spasm, that are atrophied or asleep. And you're trying to hit these, what we call trigger points, in order to get those to release. So when they usually stick a needle in a trigger point, usually you'll get a muscle that jumps. And typically what we find, and especially when we're kind of looking at these under ultrasound, because we can do trigger point releases under ultrasound, usually when we're hitting a needle into the central tendon slip of the muscle. So in the center of the muscle, there are nerve fibers that run in there. When we put that needle through that nerve fiber, it causes that muscle to jump and activate, but then relax. And so that's what we think is going on when we're doing dry needling. So we're doing a couple of things. We're trying to hit that central tendon slip, get that muscle to jump and then relax. But then also we want to create a lot of times a little bit of some micro trauma, right? So as you're sticking the needle in there, you're creating a little mini trauma. And as you create mini trauma, it's very similar to the PRP or the prolotherapy. You're going to create a micro-inflammatory response. And as you create that micro-inflammatory response, you're going to tell stem cells to go down there to repair, to heal whatever's been damaged. So it's a controlled kind of biohacking to let the body know that we have pathology here and we need to work on healing and repairing.
Very succinct. Thank you. All right. Thank you, everybody, for joining. And this message is for, I think, us both. This is a really informative session. Thank you for hosting and teaching and moderating. You're welcome. Thank you so much for joining, everyone. Dr. Ferrell, thank you so much. Thank you, Christy, as well. I appreciate you both. And we want you to come back. If you feel that there's anything that you want to share with us some more about pain relieving options or anything else regenerative medicine wise that's going on, please feel free to come back. I do appreciate your coming to share with us tonight. Is there a final thought you want to share with us?
Well, first of all, thank you for having me on here. I really appreciate it. And one area that we hit on was kind of some of the nerves, and we just really started to kind of touch the surface there. I think that another area that we're able to help out a lot with the ultrasound, the musculoskeletal ultrasound, is carpal tunnel, nerve releases, also ulnar nerve releases. So a lot of times people that have chronic nerve pain, that's another area that we're able to help them out by using ultrasound to see where the nerve is being injured, and then we can treat it directly there. And so a lot of times, people that are like, oh, I have to get carpal tunnel surgery. We come bring them in, we're able to treat them, and the majority of our patients are able to avoid that surgery.
Well, that's great. Let's see. Try not to miss anybody's questions. Oh, you're welcome. Okay, so tell us where we can find you.
Yes, so on the web, ROSM.org, O-R-G. You can find our website there. You'll find all 6 of our locations, 2 in the Virginia area, Tyson's Corner in Reston, 1 in DC at 1145 19th Street, 1 in North Bethesda across from the old White Flint, 1 in Columbia, and also 1 in Annapolis.
And the ones that you are working out of are?
Currently our DC location and our North Bethesda location.
All right. Thank you so much. And of course, if you ever need physical therapy, you can see me at LimbsNThings. And thank you so much for joining us tonight. I do appreciate you, and all that you've shared has been a wealth of information for me, and I'm sure everyone who's been watching. Thank you again. Have a good night, everybody.
Thanks for having me. Take care.